Good morning, everyone. This is Dr. Maram Abdel recording tuberculosis lecture. In this recording, we will highlight important aspects of tuberculosis epidemiology, risk factors, etiology, pathogenesis, morphology, diagnosis, and prognosis. Tuberculosis is a communicable chronic granulomatous disease caused by Mycobacterium tuberculosis, involving lungs usually, but may affect any organ. Tuberculosis flourishes under conditions of poverty, crowding, and chronic illnesses. The following groups are the most common groups affected by tuberculosis in the United States. In areas of the world where HIV infection is prevalent, HIV infection is the dominant risk factor for the development of tuberculosis. Mycobacteria are cylinder rods and considered as an acid fast, which means they have high content of complex lipids that bind the Ziehl-Neelsen stain and resist decolorization.
This figure shows a Ziehl-Neelsen stain tissue section. As you can appreciate, there are cylindrical rods that are stained with a purple color. Those are the bacilli of Mycobacterium tuberculosis.
Mycobacteria tuberculosis hominis is responsible for most cases of tuberculosis. The reservoir of infection typically is found in individuals with active pulmonary disease. Transmission usually is direct, by inhalation of airborne organisms in the aerosols generated by expectoration or by exposure to contaminated secretions of infected individuals. Mycobacterium bovis infection is contracted by drinking milk contaminated with Mycobacterium bovis. This type of tuberculosis is rare, except in countries with tuberculous dairy cows and sales of unpasteurized milk. It results in oropharyngeal and intestinal tuberculosis. Other mycobacteria, particularly Mycobacterium avium complex, are much less virulent than Mycobacterium tuberculosis and rarely cause disease in immunocompetent individuals. However, they are responsible of TB in 10% to 30% of AIDS patients. Infection with Mycobacterium tuberculosis leads to a delayed hypersensitivity reaction, which can be detected by a test called tuberculin or Mantoux test. The test consists of an intracutaneous injection of 0.1 ml of sterile purified protein derivative PPD. The test is positive if it induces a visible and palpable induration, at least 5 mm in diameter, that usually peaks within 48 to 72 hours. So negative results means that you most likely haven't been infected with the bacteria that causes TB, while positive test does not differentiate between infection and disease. It's well recognized that this test has some limitations due to the presence of false negative and false positive reactions in some cases. The false negative reactions can be related to certain viral infections, sarcoidosis, malnutrition, Hodgkin lymphoma, immunosuppression, and the presence of an overwhelming active tuberculous disease. False positive reactions, on the other hand, may result from infection by atypical mycobacteria. It's always important to differentiate infection from disease. Infection implies seeding of a focus with organisms, which may or may not cause clinically significant tissue damage. So the disease means that there is clinically significant tissue damage. Regarding route of transmission, most infections are acquired by direct person-to-person transmission of airborne droplets of organisms from an active case to a susceptible host. The pathogenesis of tuberculosis in a previously unexposed immunocompetent individual is centered on the development of cell-mediated immunity. Through the cell-mediated immunity, resistance to the organism and development of tissue hypersensitivity to tubercular antigens develop. The destructive tissue hypersensitivity is responsible of the characteristic pathologic features of a tuberculosis, such as caseating granulomas and cavitation. Figure shows the first step in the natural history of a primary pulmonary tuberculosis. The sequence starts with inhalation of virulent strains of Mycobacterium, and then the following step will follow within 3 weeks after exposure. The first step is the entry of a virulent strain of Mycobacteria into macrophage endosome. This process is mediated by several macrophage receptors, including the macrophage mannose receptor and the complement receptors that recognize several components of the mycobacterial cell walls. After entry, the organisms inhibit normal microbicidal responses by preventing the fusion of the lysosomes with the phagocytic vacuoles, allowing the mycobacterium to persist and proliferate. So during the earliest phase of primary tuberculosis, which happens during the first 3 weeks in the non-sensitized patient, a bacillary proliferation within the pulmonary alveolar macrophages and aerospaces occurs, resulting in bacteremia and seeding of the organisms to multiple sites. Despite the bacteremia, most individuals at this stage are asymptomatic or have a mild flu-like illness. This figure shows the sequence of events leading to the development of resistance to the organism and conversion to a positive result on a tuberculin skin testing. 3 weeks after exposure, cell-mediated immunity is developed. Under the influence of macrophage-secreted interleukin-12, type 1 T helper lymphocytes are generated, and they start secreting interferon gamma. Interferon gamma, released by those type 1 T helper lymphocyte, is crucial in activating macrophages. Thus, those activating macrophages in turn release a variety of mediators and upregulate expression of genes with important downstream effects, including tumor necrotic factor, inducible nitric oxide synthase, and antimicrobial peptides like defensins. Let's discuss each one. Tumor necrotic factor, which is responsible for recruitment, activation, and differentiation of monocytes into the epithelioid histiocytes that characterize the granulomatous response. Inducible nitric oxide synthase, which raises nitric oxide levels, helping to create reactive nitrogen intermediates, which are important in killing of mycobacteria. Also, antimicrobial peptides, defensins, that are also toxic to mycobacterial organisms. Activated macrophages in turn release a variety of mediators and upregulate expression of genes with important downstream effects. As I mentioned in the previous slide, they include tumor necrotic factor, which is responsible for recruitment of monocytes, which in turn undergo activation and differentiation into the epithelioid histiocytes that characterize the granulomatous response. Inducible nitric oxide synthase, which raises the nitric oxide levels, helping to create reactive nitrogen intermediates that appear to be particularly important in killing mycobacteria. Antimicrobial peptides, defensins, those are also toxic to the mycobacterial organisms. The fourth step consists of a granulomatous inflammation and tissue damage. Type 1 T helper lymphocytes aid in the formation of granulomas and caseous necrosis through the following steps. After being activated by interferon gamma, macrophages differentiate into the epithelioid histiocytes that aggregate to form granulomas. Some epithelioid cells may fuse to form giant cells. In many individuals, this response poses the infection before significant tissue destruction or illness occur. In other individuals with immune deficits due to aging or to immune suppression, the infection progresses and the ongoing immune response result in caseation and necrosis. Furthermore, the activated macrophages produce more tumor necrotic factor and chemokines, which promote and recruit more monocytes. In summary, immunity to a tubercular infection is primarily mediated by type 1 helper cells, which stimulate macrophages to kill mycobacteria. This immune response, while largely effective, comes at the cost of hypersensitivity and accompanying tissue destruction. Defects in any of the steps of type 1 T helper lymphocytes response, including interleukin-12, tumor necrotic factor, interferon gamma, and the nitric oxide production, result in a poorly formed granulomas, absence of resistance, and disease progression. Individuals with inherited mutations in any component of type 1 helper pathway are extremely susceptible to infections with mycobacteria. Reactivation of the infection or re-exposure to the bacilli in a previously sensitized host results in a rapid mobilization of a defensive reaction, but also increased tissue necrosis. Just as hypersensitivity and resistance appear in parallel, so too the loss of hypersensitivity is an ominous sign of fading resistance to the organism. This can be indicated by tuberculin negativity in a Mycobacterium tuberculosis infected patient. Tuberculosis is seen as initial infection, and in most individuals it's a self-limited asymptomatic focus of pulmonary infection. Uncommonly, primary tuberculosis may result in the development of fever and pleural effusions. Because it's asymptomatic, the only evidence of infection, if any, is a tiny telltale fibrocalcific nodule at the site of infection. However, viable organisms may remain dormant in such focus for several years and maybe for the life of the host. Those individuals are infected but do not have active disease, therefore cannot transmit organisms to others. But whenever their immune defenses are lowered, the infection may reactivate to produce communicable and potentially life-threatening disease. Primary tuberculosis is the form of disease that develops in a previously unexposed and sensitized patient. About 5% of those newly infected acquire significant disease. In the large majority of otherwise healthy individuals, the only consequence of a primary tuberculosis are foci of scarring which may harbor viable bacilli and serve as a nidus for the disease reactivation at a later time if the host defenses wane. Uncommonly, new infection leads to progressive primary tuberculosis. This complication occurs in patients who are overtly immunocompromised or who have subtle defects in the host defenses, like malnourished individuals, certain racial groups, and HIV-positive patients. In countries in which bovis tuberculosis and infected milk have largely disappeared, primary tuberculosis almost always begins in the lungs. The inhaled bacilli usually implant in the distal air spaces of the lower part of the upper lobe or the upper part of the lower lobe, and they are typically close to the pleura. During the development of sensitization, a 1 to 1.5 cm area of a gray-white inflammatory consolidation emerges. This is called gone focus, and in the majority of cases, the center of this focus undergoes caseous necrosis. This figure shows the gross appearance of gone focus in a case of a primary pulmonary tuberculosis. The yellow arrow points to a gray-white parenchymal focus under the pleura in the lower part of the upper lobe. Tubercle bacilli, either free or within phagocytes, travel via the lymphatic vessels into the regional lymph nodes, which also often caseate. This combination of parenchymal and nodal lesions is called gone complex. The figure on the right shows the gross appearance of the gone complex in a case of a primary pulmonary tuberculosis. The yellow arrow points to a gray-white parenchymal focus under the pleura in the lower part of the upper lobe. The purple arrow points to hilar lymph nodes that shows caseation. Lymphatic and hematogenous dissemination to other parts of the body occurs during the first few weeks. The development of cell-mediated immunity controls the infection in about 95% of cases. Therefore, gone complex undergoes progressive fibrosis and calcification. Despite seeding of other organs, no lesions develop.